Good afternoon and welcome to today's presentation, Every Heart is Different. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law since the expert's consent, i.e. a business relationship where she or he is hired for a particular case. In today's webinar, Dr. Mahan will discuss case studies, standard of care, expert consensus documents, competence and training statements, performance measures, what is reported to the STS database, and what do we receive. To give you a little background about our presenter, Dr. Vicki Mahan is a board-certified thoracic surgeon. She is the assistant professor of surgery and chief of pediatric cardiovascular surgery, as well as the co-director of the Hospital Heart Center. Her expertise includes valve repair and aortic surgery, brain protection during hypothermic circulatory arrest, neonatal myocardial protection, fetal pacemakers, and cardiac transplants. In her free time, Dr. Mahan is a judo student, competitor, teacher, and mentor, as well as a coach and referee. Her main responsibility in judo is to grow people. In addition, she works with teenagers and young adults in defining their career and professional goals and has recommended multiple judo students for scholarships in education, college education. Attendees who require a password, the word for today is heart. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log onto your computer as yourself and stay for the full 120 minutes. You're also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list at the widget at the bottom of your screen. Thank you all for attending today. And Dr. Mahan, the presentation is now turned over to you.
Good afternoon. I'm going to talk a little bit about two patients who presented here at our hospital to give you a little bit of an insight into how difficult some of these cases are. The first case is a full-term newborn who was diagnosed as having a patent ductus arteriosus atrial septal defect and a muscular VSD. The patient was followed by our cardiologist, doing well, and the PDA and the ASD closed. The muscular VSD was restrictive and did not need any intervention. The mother noted that the child started having respiratory issues at about 7 months of age, and at that time the child had started to eat solid food. The patient presented at an outside hospital with what the mother described as noisy breathing and a cough. At that time, the child was 12 months of age. The mother said that when the child took solids, such as bread, that she would appear to choke, cough, have difficulty breathing, and become fussy for 2 to 5 minutes. She was hospitalized after choking on pasta. The otolaryngologist saw the patient, and there was no evidence of laryngomalacia by laryngoscopy. The symptoms did not improve, and the mother said the breathing only became quiet once the child fell asleep. The child developed a runny nose and a cough, and she was seen at our hospital and admitted she had rhinovirus. At that time, she was stridorous. From the history, we were concerned the child had a vascular ring, and the echocardiogram did show a vascular ring. This was followed by a CT angiogram, which showed a double aortic arch with compression of the trachea. The child was taken to the operating room. Bronchoscopy showed extrinsic compression of the distal trachea. The vascular ring was divided. The patient is doing well and is feeding and growing without difficulty. The next picture shows what the child had. This usually is not present after birth. In utero, it is present, but if it remains Some of the children and actually adult patients can present with respiratory problems or difficulty eating. The next case is an 18-year-old who had an intellectual disability, hyperactivity, disruptive behaviors, and a truncus arteriosus type 2. He underwent repair of the truncus arteriosus as a newborn and has had 3 replacements of the right ventricle to pulmonary artery conduit, and he's known to have a hypoplastic right pulmonary artery that was dilated in July 2010. He presented with a month history of frontal headache, fatigue, upper respiratory symptoms, abdominal pain, vomiting, diarrhea, and weight loss. He had a runny nose, congestion, a dry cough, and chest pain. Blood cultures were drawn, and this grew out Streptococcus salivarius. An echocardiogram was done, which at that time, the initial echo showed a possible vegetation identified on the pulmonic valve. A CT angiogram showed no pulmonary embolism. The pulmonary outflow tract was patent, and there were post-surgical changes. The patient was admitted and started on antibiotics. Daily cultures were obtained, and the cultures were negative on 3 subsequent days. A follow-up echocardiogram, however, showed multiple large mobile echo densities on the conduit pulmonary valve. There were other abnormalities noted as well. The patient was presented at multiple cath conferences, and the decision was made by the team that the patient needed conduit replacement and dilation of the right pulmonary artery. He was taken to the operating room and underwent the 5th time redo cardiac operation, removal of an infective mass from the pulmonary contagra graft, right pulmonary artery angioplasty, replacement of the ascending aorta, right pulmonary artery reconstruction, removal of the stent inside the right pulmonary artery, replacement of the right ventricle to pulmonary artery conduit, and repair of the innominate artery using a cardiocell patch. During the procedure, interventional cardiology placed under direct vision a stent in the right pulmonary artery. On complete dilatation, there was a gush of blood to the right pulmonary artery. This was suspected to be a ruptured aorta, as the aorta was enlarged and fragile. An aortic clamp was placed, the heart was arrested, the aorta was divided just proximal to the aortic cannula, and a large posterior rent was seen in the posterior aspect of the aorta. On dividing the aorta, multiple plegited stitches were seen in the back of the right pulmonary artery, which seemed to have eroded into the aorta. The patient did well postoperatively and has been discharged. This is what the child had. He had truncus arteriosus type 2. And I presented these 2 cases. The first one, on reviewing previous echoes, the child did have evidence of a vascular ring, and we were asked whether that should have been repaired at an earlier age. The problem is that there are patients who do present with vascular rings at later ages, and there are patients who have vascular rings who do not need surgery. So the diagnosis and the timing of surgery, just because it's present on the echocardiogram, does not mean that an individual needs a surgical repair. In the second case that was quite complicated, we all knew that these vessels were fragile and friable. Truncus arteriosus is a complex congenital heart disease. We were doing the 5th time procedure going into the chest, and there was a great deal of discussion by all of the clinicians involved as to what we should do, because we already recognized that the patient would need further surgeries down the line. And the decision was made. We were forced into the situation where we had to replace the conduit. The child had endocarditis, and there was evidence of vegetations that did not resolve with therapy, and the decision was made to dilate the right pulmonary artery. What happened is not common, but not unexpected, and it was dealt with properly. So every heart is different, and what a lot of people don't understand, every heart is different and continues to change over a lifetime. The basic normal anatomy is shown in this diagram. The blood enters from the superior vena cava and inferior vena cava into the right atrium, the upper chamber. It flows down through the tricuspid valve into the right ventricle, and it goes out the right ventricular outflow tract through the pulmonic valve into the pulmonary artery, goes into the lungs where CO2 is removed and oxygen is added, and then the blood comes back into the heart through the pulmonary veins, flows down into the left ventricle through the mitral valve, and out into the aorta through the aortic valve. Posterior view, you see the four pulmonary veins coming into the posterior left atrium. You see the superior vena cava and inferior vena cava and the venous system that overlies the coronary arterial system. We have four valves, and in the normal heart, the aorta is generally more centralized. The pulmonic valve is usually more anterior, usually more superior than the aortic valve. The mitral valve is generally inferior to the aorta, and the tricuspid valve is generally inferior to the mitral valve. What many don't know is that we do have a skeletal system of the heart. It's cartilaginous in nature. And these, I'm going to show you another picture that shows where the valves are placed. Here it is. So each of the valves have a skeleton where they sit. We also have an electrical system in the heart. Most of us, our beats develop at what's called the sinoatrial node, then comes down through the right atrium, goes to the AV node, down through the His bundle, and then to the left and right bundle branches, and then into the Purkinje system. The blood flow normally goes from the inferior superior vena cava into the right atrium, down into the right ventricle, out into the pulmonary artery, comes back through the pulmonary veins, down into the left ventricle, and then out through the aorta. The amount of blood flow that flows out of the heart is dependent on the heart rate and the stroke volume. The heart rate and stroke volume are dependent on several factors. This can be adjusted based on medications as well. But in terms of the stroke volume, it's dependent on the amount of blood, the preload, how much blood is in the heart, the afterload, which is basically blood pressure, and how well the heart contracts. We can increase our heart rate by several different methods. Exercise is the commonest. In the newborn, the child is not usually able to increase the stroke volume as in a normal heart and is very dependent on the heart rate. In the adult with a very sick heart, they also are not able to increase the stroke volume and are very dependent on the heart rate. We generally we usually talk about the cardiac index, which is the cardiac output divided by the body surface area. Again, this is another diagram showing control of cardiac output. If we have a vagal maneuver, we slow our heart rate, we have a press down, what will happen is the heart rate will slow. There are things that increase the heart rate, like we get excited or something. The venous return, when we stand, the venous return drops. When we lay down, raise our leg, the venous return increases. I wanted to show this picture because there are many different types of coronary arteries. And if you look at angiograms, not only on the pediatric population, but also on the adult population, there are a lot of variabilities. This is important when we're operating on both populations of patients. And in a normal, healthy heart, the aortic valve closes where there's not blood flow and going back into the heart during diastole. That's when the heart is filling. The heart valve also opens fully. A stenotic valve does not open fully. And then what about the congenital heart defects? About 1 in 100 children are born with a congenital heart defect of some type. The majority do not need surgical intervention. The majority close on their own or are not deemed necessary to need an intervention. The most common abnormality is what's called a ventricular septal defect, and that's where you have a hole in the septum between the left ventricle and the right ventricle. The majority of those patients do not need surgical intervention. There is a population of patients, about a fourth of the patients who are born, who will have what's called critical heart disease. And those patients who have the more complex heart disease, the death rate in the neonates is about 4.2%. Again, this shows 1 in 100 babies is diagnosed with heart disease at birth worldwide. In Lebanon, about 700 newborns are born with heart disease every year. About 400 and 700 will need some form of surgical intervention or non-surgical procedure. There are a lot of different professionals taking care of all of these patients. I put this one in on adult congenital heart disease, but with all heart disease, be it adult or pediatric, a lot of professionals are involved in the care of these patients, not just the cardiologist and cardiothoracic surgeon. And not all of these patients need intervention. Just because you have it doesn't mean something has to be done. We do define stage A, stage B, stage C, and stage D, where like stage A is high risk with no symptoms. It may be someone who has high blood pressure or diabetes, and we can manage that. Stage B, you have a situation where the abnormalities are starting to develop. They may need some intervention to manage hypertension, diabetes, their lipid problems. Stage C, you usually do develop symptoms, and generally there's an increase in medical treatment. This is usually a stepwise progression, and the patients are followed closely, not only by their primary care physician, but generally by a cardiologist as well. And the signs and symptoms are not classic in the majority of the patients. Many people do not understand the first presentation of a heart attack is sudden death. They don't have other symptoms. The individual who comes in, who you know is at risk for a myocardial infarction, says, I just don't feel good. You better start thinking that something's going on with the heart. There are several different presentations. You can have a normal EKG and still having a heart attack. And some of the things that are seen, you feel lightheaded, you're pasty, you're sweating. You feel palpitations, flip-flops of the heart. You have nausea. You may vomit. Some patients have difficulty breathing. The chest pain is many times not in the mid-chest. They'll say, my arm hurts, or my left hand hurts, or I hurt down in the abdomen. And in the infants who are having cardiac problems, it's more difficult because they can't talk with you. The neonates and infants are not eating well. They become tachypneic when they're eating. It takes a lot of cardiac output to feed, to eat. They have poor weight gain in older children. They're tired easily. They can't keep up with the rest of the kids. They're short of breath. You start noticing that they have some swelling down around the ankles or around their eyes. They're not growing like they should be growing. And the etiology of the failing heart is very different in the fetus versus the premature neonate, the full term, the infant toddler, the child adolescent, and then the adult. There are very strict standards of care for the cardiologist and the cardiothoracic surgeon. We have guidelines put out by the American College of Cardiology and the American Heart Association, and there are multiple specialties that are involved in creating these guidelines. We have the STS database, which is being converted into the World Database. We have the American College of Cardiology, National Cardiovascular Data Registries. I'm going to talk a little bit about the American College of Cardiology and American Heart Association guidelines, expert consensus documents, competence and training statements, performance measures, appropriate use criteria, health policy statements, data standards, clinical alerts, other, where we put out a paper based on interest, and survey and data reports. These are available online. You go to ACC guidelines, and you can pull these up on your own. The public can pull these up on their own. So guidelines. The guidelines that were put out in 2018 included guidelines on blood cholesterol, bradycardia, and cardiac conduction delay, and adults with congenital heart disease. In 2017, guidelines were put out on high blood pressure in adults, ventricular arrhythmias and the prevention of sudden cardiac death, heart failure with a focused update, valvular heart disease with a focused update, syncope, and clinical practice guideline implementation strategies. These go back many, many, many years, and if you go into the ACC guideline website, you can actually look and see which guidelines are available. We try to update these every 3 years, and this is based on what literature is coming out. So, as an example, I took the 2018A guidelines for the management of adults with congenital heart disease. Adults with congenital heart disease now outnumber pediatric patients with congenital heart disease, and this has become a problem. The older cardiologists had dealt with the patients as they grew up. But what has happened is we now have patients with complex congenital heart disease who are living into adulthood, and we are now seeing things we never saw before. There is now a new field in cardiology which is board certifiable, and it's adult with congenital heart disease, and you can come up through the internal medicine side, do internal medicine, adult cardiology, and then do a fellowship in adults with congenital heart disease, or you can come in through the pediatric side, and you do pediatrics pediatric cardiology, and then do a fellowship in adults with congenital heart disease. Cardiac surgeons are different. Cardiac surgeons do generally general surgery, and then they do cardiac surgery, and then they do pediatric cardiac surgery. So I'm boarded in cardiac surgery and in general surgery, and we have a board for pediatric congenital cardiac surgery. The people who write the guidelines are not just cardiologists. And if you look down through the names and everything, there are adult cardiologists, pediatric cardiologists, cardiothoracic surgeons, there are radiologists. There is a group of people that write these different guidelines. And the American Heart Association and the American College of Cardiology have very strict criteria as to who are put on these writing committees. I wanted to go through this because in medicine, in cardiology and cardiac surgery, it's very common knowledge to us as to how, what the classes are, what the recommendations are, what the level of evidence is. In Class 1 recommendation, the benefit greatly outweighs the risk, and the procedure, the treatment, should be performed or administered. So phrases for writing the recommendations are, it should be done, is recommended, is indicated, is usually effective or beneficial. In the Class 2A recommendation, the benefit outweighs the risk, but is not as high of a level as in a Class 1 recommendation. So additional studies with focused objectives are needed. And the phrase usually means that it is reasonable to perform procedures or administer treatment. So in lay terminology, it's reasonable. It can be useful, effective, beneficial, is probably recommended or indicated. In Class 2B, the benefit still outweighs the risk. Additional studies with broad objectives are needed. Additional registry data would be helpful, but the procedure or treatment may be considered. So, talking to the lay people, it might be considered, might be reasonable. The usefulness, effectiveness is unknown, unclear, uncertain, or not well established. We then have the Class 3, where there's no benefit, or the Class 3, which is harmful. And I want to go to the next slide to talk about the level of evidence. In Level A, you have high-quality randomized clinical trials and a meta-analysis of high-quality randomized clinical trials. In Class 2B, you have randomized and non-randomized trials, but they're not as high a level as your Level A. Your Level C is broken down into limited data or expert opinion. Every year, more and more clinical trials are being performed, and every year, more and more information is obtained through the different registries, the STS database, the ACC, the AHA, so we can make higher level decisions regarding our decisions and what our recommendations are. So if you look at this paper on adult congenital heart disease, the recommendation for access to care is a Class 1 recommendation, and physicians caring for patients with adult congenital heart disease should support access to care by assuring smooth transitions for adolescents and young adults from pediatric to adult providers. The level of evidence is B, non-randomized. But it's also a Class 1 recommendation that the physician should promote awareness of the need for lifelong specialized care through outreach and educational programs. This level of evidence is expert opinion. There have not been studies on this particular aspect of care. Another Class 1 recommendation is the recommendation for transition education. Clinicians caring for patients with congenital heart disease should deliver developmentally appropriate transition education to adolescent and young adults with congenital heart disease and to their family support network. This level of evidence is B, non-randomized. So throughout the paper, you'll see these little blocks making recommendations, and they will give you the class of recommendation and the level of evidence that is available. Now, what about the expert consensus documents? The ACC expert consensus documents in 2018 were on tobacco cessation treatment, cardiovascular risk reduction in patients with type 2 diabetes and atherosclerotic cardiovascular disease, myocardial infarction, fourth universal definition of, and the definition of myocardial infarction is changing, and it's changing drastically. Transcatheter aortic valve replacement, operator and institutional recommendations and requirements, expert consensus systems of care, optimal use of ionizing radiation and cardiovascular imaging, best practices for safety and effectiveness. These expert consensus documents are only from 2018. As before with the guidelines, there's a long list of expert consensus documents. Now, I chose the expert consensus system of care document on operator and institutional recommendations and requirements for transcatheter aortic valve replacement. And I did this because this involves both cardiac surgeons and it involves cardiologists. I was in one of the programs where we were doing the clinical studies. I had to scrub in with the cardiologist while they were delivering the transcatheter aortic valve. This has now become a standard of care where I don't have to scrub in. I have to be available in the hospital. Dr. Joe Bavaria is one of our senior cardiothoracic surgeons. Craig Miller also is a senior cardiothoracic surgeon, as is Dr. Sunt. So in this document, what they talked about is what the primary objectives, what they want to do is achieve high-quality outcomes for patients who have clinically significant aortic valve disease, be it aortic insufficiency, aortic stenosis, or a combination. They talk about what the measures of quality of the operators and institution. It requires a lot of skill, experience. The TAVVR and SAVR, the surgical aortic valve replacement, they're not competitive. We help each other make the decision in each individual patient. The facilities must be available for delivering when you're talking about the newer technique, the transcatheter aortic valve replacement. You have to have surgical availability in case there is a problem. There is a large multidisciplinary team that is mandatory for the program. And it's a based joint cardiology and cardiac surgery effort. Both the cardiologist and the cardiac surgeon have to evaluate the patient. There are other providers. We don't usually, as cardiac surgeons, need fluoroscopy available. The cardiologists do. And the cognitive and technical skills that are required of multiple specialties, not just the cardiologist and the cardiac surgeon. Our anesthesiologist, our radiology colleagues, the other individuals in the operating room have to understand that this is a technique different from a surgical aortic valve replacement. Training now is by two different pathways. Formal training programs have now been developed. When I was doing it, we had formal proctorships. The program, the institution that wants to do transcatheter aortic valve programs has to have an active surgical valvular heart program. And there has to be at least 2 cardiac surgeons who are good at aortic valve surgery. The other issues that we begin to address is that in terms of doing it in patients who do not have a life expectancy greater than 1 year. These are things that are being addressed by the cardiologists, by the cardiac surgeons in many of these papers. There are different processes that are in place in terms of informing the patient as to what the pros and cons are for the transcatheter approach versus the surgical approach, and having to switch over from a transcatheter approach to a surgical approach. The outcome measures include risk-adjusted all-cause mortality, 30-day risk-adjusted all-cause mortality, all-cause neurologic events, including transient ischemic attack, vascular complications, 30-day major bleeding, and 30-day moderate or severe aortic regurgitation. There is now a registry. STS database is now intimately involved in following these patients. And there are different requirements needed for initiating a program, a new program. There are minimum volume requirements for the cardiologist. And for the older programs, the quality and quantity are actually at a higher level than for the newer programs. We have competence and training statements. The ACC, AHA competence and training statements for 2017 included clinical cardiac electrophysiology specialist lifelong learning statement, advanced heart failure and transplant cardiology advanced training statement. And as before, there are many, many more during previous years in terms of competence and training statements. So for 2017, the advanced training statement on advanced heart failure and transplant cardiology, again, this includes not only cardiologists, but it includes cardiac surgeons as well. Cardiac surgeons, cardiologists are both intimately involved in the care of these patients, and these documents are written as a team effort. What has happened now with advanced heart failure is there are fellowships not only for the cardiologist, but for the cardiac surgeons as well. It is a subspecialization now. And the training and the advancement in the field requires ongoing education, and that has been recognized. The cardiologists that are coming out of their 3-year training, many of them will take a fellowship to become subspecialized in this field. And they are required to know how to handle the different devices and the complications, including thrombosis, stroke, infection, bleeding, and pump malfunctions. These patients, be it pediatric or adult, are highly complex patients, and there's generally a special team that takes care of these patients, and there's generally special numbers that both the surgeons and the cardiologists must meet in order to take care of these patients. So this goes on to discuss what the trainee must learn, outpatient and inpatient management of the patient. And it's very extensive, and there are educational guidelines for the individuals who are managing patients with advanced heart failure. Unfortunately, more and more patients are going into the category, and despite what we have available, many of these patients will need ventricular assist devices and or placement on a transplant list. To continue, there are also performance measures. In 2018, something that they tackled included cardiac rehabilitation, clinical performance, and quality measures. Again, the ACC, AHA performance measures, there are a lot of papers discussing different performance measures for different topics through different years. With the cardiac rehabilitation, the cardiologists are usually involved in this more than the surgeons, but the surgeons have are becoming more involved in this, especially on the pediatric cardiac surgery side. There are different guidelines, and the problem that was identified is that cardiac rehabilitation is not being offered or pushed for the majority of the patients, and this is an area that we can improve in. It's clear that cardiac rehabilitation, under the best of circumstances, will help the patients in terms of the healing process, quality of life, and quantity of life. This shows how the development of the program progresses and areas that need to be addressed. The appropriate use criteria. Many patients don't understand that cardiologists and cardiac surgeons don't just order a test. There are guidelines. There are guidelines for ordering an echocardiogram, for an EKG, for a Holter monitor, exercise tolerance testing, cardiac catheterization. If you do a cath, are you allowed to do a percutaneous intervention with balloon dilatation? If you can, are you allowed to do all of the vessels that are affected? There are strict appropriate use criteria and guidelines that address these. As in the regular guidelines, there are a lot of appropriate use criteria papers back through multiple years. Multimodality imaging in the assessment of cardiac structure and function in nonvalvular heart disease is on the minds of a lot of the cardiologists and cardiac surgeons right now. The issue of using cardiac MRIs, CT angiograms, rather than using cardiac catheterization has not been fully answered. And many are very used to cardiac catheterization, but there is a lot of radiation associated with that. Some of the different modalities give you more information than what the cath can, So there is a different studies can complement each other to give you a better idea of what's going on, not only anatomically, but physiologically as well. And usually, a lot of folks don't realize that usually there's more than one imaging modality used. The non-invasive technology, the echocardiogram, to look at the heart, it gives you a lot of shadows. The 3D echoes give you a better impression of what's going on. But now with the dynamic cardiac MRIs and the CT angiograms, those actually complement echocardiography and help us better understand what is going on in a particular heart and in a particular patient. With appropriate use criteria, there is a scoring system in place. And basically what you do is you read papers and you determine, based on the paper, whether a particular technique is appropriate. That is a median score of 7 to 9, and there are multiple people who read the different papers. Or if it may be appropriate, a score of 4 to 6, or if it's rarely appropriate, a score of 1 to 3. So generally what's done with the scoring system is that the papers are pooled. A lot of individuals, cardiologists, cardiac surgeons, many times radiologists, review the paper and then put a score down from 1 to 9, and then you get a median score and you end up writing a paper. There are health policy statements that are put out by the American College of Cardiology. They're not as frequent as some of the other guidelines. What the most recent paper was on the transformation in the era of digital health, big data, and precision health. And this was on drug development, learning from sildenafil. What is happening with our ability to record data in the electronic system? We're able to move that to a lot of reviewers, and we're able to do statistical analysis on that and ask specific questions. So we're not limited to what's happening in a single hospital. And what is happening with a lot of the information that is being recorded in the databases, it's not only within the United States, but it has gone to the international level as well. So a lot of the information that is now being recorded in papers is from not only the United States, but it's also from the international level. And that's important. Part of the problem is there is differences in the different populations. And that's something that many people are trying to work on, to sort through the discrepancies in the different demographic populations. So in terms of a health policy statement on healthcare transformation in the era of digital health, they were looking at, in 2016, they were looking at digital health, big data, precision medicine. One of the big problems is comparing apples to apples rather than apples to oranges. And that is what cardiology and cardiac surgery is now trying to do. And as can be imagined, we need a lot of researchers with a knowledge of database management, a lot of statisticians who know how to look through this, and just inputting the data is a big deal. And I'm going to go through that when I talk about the STS database. So this was discussing basically the use of data in the healthcare system. And this is a big deal in terms of harvesting or looking at information in electronic medical systems. There are a lot of electronic medical systems that are out there, and they're not all the same. And in fact, in the same institute, you can have the outpatient side being different from the hospital side, and the systems don't talk to each other, and that is a huge problem. So the American College of Cardiology and American Heart Association also wanted to look at data standards, and they began to look at electronic health records in pediatric and congenital cardiology, looking at key data elements and definitions back in 2017. People began to look at these different clinical data standards and how to input it and what's important and what's not important. And it becomes problematic because there's an awful lot of information out there. And the question is, what information do you put in? And if it's put in on the East Coast, is it same as the information put in on the West Coast? And what system are you using to analyze the data? And what hardware are you using to do, for example, a cardiac intervention in the cath lab? So there's a lot of different systems out there, and what we're trying to do is make sure everyone's looking at the same kind of information. And the electronic, with the kids in particular, one of the problems at a lot of the institutes, the people who work with children, neonates, understand that the adult systems do not work for the children and neonates for various reasons. And the cardiologists, cardiac surgeons are in the process of trying to define what has to be in electronic health records if you're using an electronic system, in terms of developing a plan for the patient and in order to communicate information to other healthcare providers wherever they are, be it here in Philadelphia or if it's across the nation or if it's international. And we want to develop a consistent, interoperable, and universal clinical vocabulary. And that's really important, especially in the pediatric populations, and especially pediatric patients who have congenital heart disease. So, Rochelle, I've come to the slide on question and answers.
Thank you, Dr. Mahan. If all the attendees can enter in the passcode for today, which is HEART, and any questions that you may have. Our first question is, are there guidelines for persons with AFib?
You're going to have to say that again. Are there guidelines for Yeah, and I'm gonna go into that when I get to the National Cardiovascular Data Registry. That is a big area of research right now. In terms of atrial fibrillation, 10, 20 years ago, we kind of ignored it. We didn't think it made a difference. And we have learned that getting the patients back into a sinus rhythm is extremely important, not only just for their heart, but for their quality and quantity of life. So there's a lot of ongoing research, and there is actually a National Cardiovascular Data Registry specifically for that.
Next question. How is a stroke related to the heart? It seems to be involved brain mostly.
Can you put that up on the,
Sure.
Yeah. Oh, the unfortunate situation, there are two issues here, basically. Number one, if the heart has something in it, like a clot or a vegetation or a calcification from a sick valve, when the heart beats, those can be sent out of the heart, and they can go to the brain, unfortunately. They can also go to other organ systems. And the other problem is that you can have communication between the left and the right sides of the heart, and you can have something on the right side of the heart, like a clot, or again a calcification or a tumor on the right side of the heart. One of the ones that's famous is renal cell carcinoma. And if there's a hole between the right and left sides of the heart versus via something like an atrial septal defect or ventricular septal defect, those can go to the left side of the heart, be ejected into the aorta, and those can go to the brain, or they can go to other organ systems, pretty much all organ systems. You have no control where those embolize to. So these are emboli, and this is real problematic in the atrial fibrillation patients, where we know they have a higher incidence of stroke. And one of the reasons we try to get them out of AFib is to decrease the incidence of stroke. And the other reason we try to get them out of AFib is because that atrium is quivering and blood clots in that atrium, and so the patients are at a higher risk of stroke. They form clot more easily.
Next question. Is there any significance in the STS falling out in an EKG?
I don't know what that means. The STs falling out? The ST segments are after the QRS, and generally they're at the same level where the P wave, they're at a baseline level, or they're elevated, or they're depressed. I'm not familiar with the terminology falling out. They can become depressed, or they can become elevated, but falling out, I haven't heard that terminology before.
Next question. What is a vegetation in the heart?
What is the... vegetation, unfortunately, means when we look at the echocardiogram, it means there is something that is not normal. And when we communicate among the cardiologists and cardiac surgeons, one of our primary concerns is that it's infected. It's a bacteria or something. It can be due until you get it under the microscope. Many times we don't know exactly what it is, but it can be due to an infection like endocarditis, or it can be due to a clot. It can be due to what's called pannus formation. That's an overgrowth of normal tissue. It can be due to a cancer. You get cancers in the heart. So a vegetation is something that there's a mass there. We're not quite sure exactly what it is, but it shouldn't be there, and it can do something bad, like go outside of the heart, to the brain, to the kidneys, to the GI tract, to the eyes, to an area you don't want it.
Next question. Are there TAVR standards as to when to convert to an open AVR surgery?
Actually, yes, there are. And those guidelines are being changed. There's a lot of change of transcatheter aortic valve replacement indications right now. And this is a field where all of us as cardiologists, as cardiac surgeons at actually the international level are determining when the patients, number one, should not have a transcatheter aortic valve replacement. And in the United States, what the initial recommendations were is that transcatheter aortic valve replacement should be offered to a patient who is too sick to have a surgical aortic valve replacement. And one of the problems with that is the heart is very sick. And in that situation, if they rupture the aorta, or if they tear the valves, or if it doesn't deploy properly, we as cardiac surgeons have to basically go in and bail them out. Now, the systems that we're using are getting better. In the United Kingdom, who's taken a lead on this, the United Kingdom is now offering younger patients a transcatheter aortic valve replacement rather than surgical aortic valve replacement. The United States is starting to do that as well. So in terms of TAVR switching over to an AVR, the major indications is the valve, the device does not deploy properly for whatever. You don't have the right angulations. There may be situations where you cannot dilate the annulus. There's too much calcification. And the bad ones are that everything is ripped, where you have a rip outside of the annulus or the aorta, where the surgeons have to be available immediately. Usually when these are done nowadays, cardiologists and cardiac surgeons communicate very closely. And even though I, as a cardiac surgeon, they're now to a point where they don't need me to scrub in. We usually have an operating room available, and we have a perfusion team available as well. We may not prime the pump, but we have everyone available in case there is a problem.
Thank you, Dr. Mahan. You can continue with the presentation.
Okay, thank you very much. So there are clinical alerts that are put out, and these are put out by the ACC, the American Heart Association. They're not as commonly put out as the guidelines and the appropriate use criteria, but they're put out many times as science advisories. These are generally topics where there's not a lot of randomized clinical trials. They're on the minds of cardiologists and cardiac surgeons, and you say, what do I do? And you basically sit down and ask a question and have experts and say, well, maybe we should do this. Let's go look at the literature, see if there's anything that supports it. So generally, depending on the topic, you can have just cardiologists, or you can have cardiologists and cardiac surgeons. I'm involved in one of these right now, where it's neonates with critical congenital heart disease. Should they be admitted to the neonatal intensive care unit or to the cardiac care unit? And what I have requested, I'm the primary author on this, and I have requested an individual who is board certified in neonatology as well as pediatric cardiology, someone who is boarded in neonatology with an interest in cardiology, pediatric cardiology. I've requested an intensivist, a pediatric intensivist, who has done a fellowship in the new field, and that's pediatric cardiac intensive care unit. And I've requested an administrator who knows what the problem is in terms of where you put these patients. So it really depends on what topic you're interested in discussing. Generally, it's a topic on everyone's mind, and there's not a lot of information. Now, hypertension most definitely is on everyone's mind across the world, and it affects an awful lot of patients. And not only that, we're finding out the numbers that we used to use are probably too high, and we need to start thinking of blood pressure, hypertension being present in individuals who have a systolic pressure greater than 120 and a diastolic pressure greater than 80. And another thing that a lot of individuals don't know is that high blood pressure begins in utero. And one of our major failings is that we have to define this at a much younger age, in the newborn, in the infant, in the toddler, in the pediatric population, the adolescents, the young adults. This is not a problem of just older adults. And our primary care physicians are really helping us a lot with this. And the management of these folks, patients with hypertension, and it doesn't matter if you're an adult or a child, it's multifactorial. It's not just give you a patient a medication and everything's all okay. That's not the truth. You need to have the patient helping you out. You need to have the families involved, the diets, exercise, the providers, and the communities. All of these have to be involved. Hypertension is extremely common in our African American males, and when they have hypertension, they have a higher incidence of other problems, to include heart attacks, strokes, renal disease. So this adds problems, and if we don't address it early, we're going to have more major organ system failure that has to be addressed later on in life. So people look at what the best practice, evidence-based management, and what is happening in conjunction with this is that not only are you addressing diets and you're addressing physical activity and that sort of thing, the pharmaceutical companies are actually getting, their medications are getting better, and fortunately the generics are getting cheaper. And the information is now getting out to the population at large through different techniques, through the primary care physicians, television, our educational systems, our basic elementary schools are getting this out. Our preschools are getting this out as well. So we're starting to develop game plans in terms of how to deal with this from the fetus through adulthood and in the older adult populations. And by the patients may have different reasons for their blood pressure problems, and these have got to be defined. There are patients who have hypertension in combination with different clinical conditions. There are specific medications that have to be considered. We have a large population of patients with coronary artery disease, who have had AMIs, who need to be on beta blockers or need angiotensin-converting enzyme inhibitors. We have patients now who have a lot of systolic heart failure. Patients are living longer. They used to die, but they're living longer. And we're trying to figure out how to give these patients, these people, a quality and quantity of life. And the diabetics are a big population that are difficult to manage. Patients with kidney disease, unfortunately, kidney disease patients, almost every one of them have hypertension, and patients with stroke and transient ischemic attacks, the majority of those patients have hypertension. So this is on everyone's mind. We're trying to get everyone involved. We're trying to get the education out there, and we're trying to get people to understand. Start making the diagnosis early in life, and just because the blood pressure is normal in a young adult doesn't mean that the pressure is going to be normal when you're in your mid-30s, mid-40s, etc. There are other topics that come up that are on the minds of clinicians, and they'll write into the ACC, AHA, who form the writing committees, and say, this has come to the forefront. We need to take a look at this. Well, the most recent other paper that was written was on Fontan-associated liver disease. And Fontan procedure is done in patients with complex congenital heart disease, and it's patients who have what's called single ventricle physiology. Only one ventricle functions. And 20 years ago, these patients did very poorly, and the majority of these patients died. Well, we've gotten a little bit smarter. We've gotten a little bit more knowledgeable, and we're able to get these patients, in many cases, we're able to get them into at least their teenage years, and there are now patients alive with the older Fontans in their 50s. And as these patients get older, we're finding different cardiac pathologies that we never knew about. So with the Fontan-associated liver proceedings, basically this is a hookup. The quick and dirty description is the blood vessel draining the lower body is hooked up to the pulmonary artery. The blood vessel draining the upper body is hooked into the pulmonary artery. So there's not a chamber in the heart that pumps blood into the pulmonary artery as in the normal heart. The unfortunate problem is that the majority of patients with this hookup have at least some liver dysfunction, and there is a percentage of those patients who go into liver failure, and there's a percentage of those patients who have cancer of the liver. And what's happening now is that there's becoming a percentage of these patients that need to be listed for liver transplant, and they have a complex congenital heart disease. And the questions we are asked, is there something surgically we can do to make the liver better? Or is there something that the cardiology doctors can do to put them on a medicine to make them better, or perhaps to create an opening at the atrial level where you have what's called a pop-off valve that will decompress the liver? There's a lot of discussion as to how to handle these patients, and this is on the mind because now these patients are starting to be guided towards liver transplants, and the question everyone wants to ask us is, well, how long are they going to live? And the answer that we generally give is we don't know, because these patients used to die, and they used to die from their underlying cardiac disease, and they're no longer dying from their underlying cardiac disease. So we now have to create a situation where you have a patient population living to their adulthood who are now being considered for liver transplant, and they have other pathologies of their liver that we need to pay closer attention to. This usually doesn't happen during the teenage years or the early adult years. Usually it happens when you start hitting your 30s, 40s, that sort of thing. So the ACC, AHA also look at survey and data reports, and we do workforce assessment and staffing, and a lot of people don't know that we've become short on physicians. cardiologists, cardiac surgeon across the board, we're short on physicians. And worldwide, we're definitely short on physicians. And what's kind of amusing is people talk about primary caretakers. Every one of us who are subspecialized, we also practice primary medicine. And a lot of folks don't understand that. But the workforce assessment on cardiology, they said, hey, guys, we don't have enough people here. What are we going to do? So they were trying to clarify what the numbers were and how they could improve the numbers and how they could improve the educational system so that we could make sure that we had enough cardiologists within the United States to take care of the population of patients. By the way, we're still short of cardiologists and cardiac surgeons. So I wanted to talk about the Society of Thoracic Surgeons database, and this is something that the majority of people who are in medicine know about, and certainly a lot of lawyers know about, and it's not an easy thing to understand. This was established back in 1989. The Adult Cardiac Surgery Database was the first, and it was established by cardiothoracic surgeons in order for us to get better, to help each other. It was an initiative for quality improvement and patient safety among cardiac surgeons so we could talk to each other. Since it was initially established, there are now 4 databases: the Adult Cardiac Surgery Database, the General Thoracic Surgery Database, the Congenital Heart Surgery Database, and the INTERMEX database. And people think these are when you talk to hospital administrators, they think that this is fairly simple until I sat down and said to my chief of surgery, do you know what this is? At which point, I don't have any idea. And if you go into the website, all you have to do, this is not secret or anything, go into STS databases, and you can see what each of these entails. The Society of Thoracic Surgeon, our leaders were actually called before Congress because people had looked at this and they said medicine needs to be transparent. And we had established a database in adult. And by the way, these are expanding on a yearly level, the amount of information that is being entered. And the Congress wanted to say, well, what are you guys entering? How are you doing it? Shouldn't this be taking place in the rest of medicine? And what's happened is a lot of the fields of medicines have looked into this and are developing their own database. We also believe that the public has the right to know and to understand what's out there. And there's a public reporting system. The public, anyone can go in and take a look and see what's out there. We have to give permission to use our data. Our hospital, almost all of us, give permission to use the data from our own institutes. So public reporting is now available in the Adult Cardiac Surgery Database, General Thoracic, and Congenital Heart Surgery. The last one is relatively new, and we're trying to get that together. And there's crosstalk with that database and the other databases as well. STS is considered a leader in the quality arena. It's involved in numerous quality initiatives and activities. And these databases are used for quality control, and they're used for writing papers. And that's why we want them as clean as possible. The society has developed quality performance measures in the areas of adult cardiac, general thoracic, and congenital surgery, and these measures have been either endorsed or are in the process of being considered for endorsement by the National Quality Forum. The database, designed as a quality improvement tool, offers participants the opportunity to compare their outcomes against the STS national benchmark, and participants can use this information to identify appropriate areas for improvement. This information, when we get our feedback, it's not available just to us. It's available to the hospital as well. The problem is the information we get back is a very thick binder, and the administrators, the individuals who know how to read these reports, are the cardiologists and the cardiac surgeons. And we're very happy to sit down with administrators or chiefs or whoever wants to talk about it, and go over them. It offers, let me go to the next slide here. These databases also have checklists that have been developed. This happens to be a congenital heart surgery checklist. And at sign-in, when the patient comes in the room, time out before the incision is made, and also there is a sign-out when you deliver the patient to the intensive care unit. And if you look at the bottoms of this, the surgeon also has to sign, and it may be someone from the surgical team. There is not a single surgeon. In our operating room, 3 cardiac surgeons sign in because we're doing scrub in because we're doing complicated cases. At the place I was at, Beth Israel and Harvard, there were almost always 2 cardiac surgeons, but we were doing complicated cases. They are not just a 2-vessel cabbage, or you have to take the valve out and put in an aortic valve in someone who's nice and healthy. Usually we ended up with the complicated cases. This TAVR, the STS, and the American College of Cardiology TVT registry, it's the main repository for clinical data related to transcatheter aortic valve replacement. All of us recognized that this was going to be a dual effort on the part of cardiology and cardiothoracic surgery. So not only are the cardiac surgeons involved in this, but the cardiologists are also involved in this. This is between the STS and the American College of Cardiology. It monitors patient safety and real-world outcomes related to transcatheter aortic valve replacement. Now, transcatheter aortic valve replacement sounds like a super idea when people are saying, oh, I don't want to have my chest cut, I don't want to go on the heart-lung machine, etc. The problem with transcatheter aortic valve replacement in the initial studies is there's a higher risk of stroke. The reason is because of what the cardiologists have to do to dilate the aortic valve and the annulus, and the initial studies were done in patients who were deemed too sick to undergo surgical aortic valve replacement. As we get to patients who are not as sick and who don't have as much calcification of the aortic and aortic valve, we're hoping that the incidence of stroke is lower. It's closer to that of the surgical aortic valve replacement. If you tell me I need an aortic valve replacement and someone says, oh, I can do it with a transcatheter approach, and it's as safe as or safer than doing it surgically, yes, I would say, well, give me the transcatheter approach. The data from the national database, this is a huge amount of data. It's monstrous. It's available to physicians, researchers, and the healthcare industry to use for quality improvement. and in comparative effectiveness research, clinical trials, post-market surveillance, and basic and translational research. Any one of us can ask for information. It goes through committees as to whether this question should be asked or not asked, and we can argue. If one of my requests was denied, I could argue, but their reasoning was very logical. Said, okay, well, I can do this a different way. So I'm going to come from the standpoint of the congenital heart surgery database, which is very complicated. So what is reported to the STS database? Well, first of all, our database has just been updated in January 2019. And there's new hardware available, and we have to switch our hardware. And there is a huge training manual, a database training manual, which is about 6 inches thick. And there's ongoing teleconferencing, and there are actually meetings to discuss the databases. Be it they have a meeting for congenitals, adults, thoracic, diabetics, that sort of thing. So this is an ongoing educational process. Now, the congenital heart database, we usually do harvests twice a year. The thoracic does it twice a year. IMEDIX does twice a year, and I think the adult cardiac does it 4 times a year. So, for example, the opening date for our spring 2019 harvest, the opening date was October. They opened the computer system up in October 22nd, 2018, and they said the reporting period is from January 1st through 2015 through December 31st, 2018. And the report will be posted at the end of May. So they're usually delayed. They haven't reported that back to us. And they're usually delayed by about 6 weeks. So we're hoping they're going to we're going to get that in the next couple of weeks. This is a public reporting harvest. If you look at the reporting period, it's always a 4-year period. Ours is every 6 months, so what will happen is the first 6 months of 2015 will fall off, and then we'll go through June 30th of 2019. So from version 3.41, which is the most updated version, there is administrative information that is entered, and they want to know if we're on a clinical trial for a particular procedure. And then there's demographic information. And then a lot of people don't know we have a lot of birth information in there as well. And the information gets as nitty-gritty as what were the APGAR scores. Were there any problems? Did the mother have any problems? So it gets pretty complicated, and you have to pull this information. And if the baby wasn't born here, we have to go back to the hospitals where the baby was born with the mother's and father's permission. And then there's other information, non-cardiac congenital anatomic abnormalities. Many of the children who have a congenital heart defect of whatever type have other congenital abnormalities. And we're finding a lot of this is genetically related. And that's important because if you have someone with what's called a trisomy 18 and their longevity in life has already been defined, and those patients really don't live in past 1 year of age, should you really be doing anything surgically on that child? And it gets into ethical questions. And then it gets into chromosomal abnormalities. We have here where I work some of our geneticists we have Dr. DeGeorge was here, and Dr. DeGeorge diagnosed DeGeorge syndrome, which is very definitely a genetic abnormality, and because of that, we have a lot of people who kind of migrated with genetic abnormalities to our facility, patients and their families. And so we have a lot of genetic defects in patients here, and we have a very extensive genetic lab, which is not present in a lot of places, but we have it. And a lot of our children have syndromes, which Downs is the most common, but we have a lot of Turners, a lot of Williams, and there are names associated with these, but we have a lot of syndromes at these hospitals, children who are not normal. And then we look at what their people kind of want to know what the insurance is, and there are preoperative factors that are extremely. Were we forced into a situation where we had to operate? Did the child, as a newborn, have seizure? Has the child had a stroke? Is the patient infected? Does the child have renal disease? And what is the diagnosis? For someone to say, my child has an atrial septal defect, that really, as a cardiac surgeon, that doesn't help me a lot. First of all, there are 5 different types of atrial septal defects, and not only are there 5 different types of atrial septal defects, many of these go along with other pathologies in the heart. So when we start identifying what the diagnosis is, we have to sit down and say, does this child have an ASD with a PDA, with a VSD? Where are the ventricles located? You have to fine tune your diagnosis of what the congenital heart disease is. And then this just went through some of the others, like an aortic stenosis or left ventricular. There are different types of aortic stenosis. It's just not valvular. You can have subvalvular, supravalvular. You can have extending to the left ventricle apex. You can have supravalvular extending out into the ascending aorta and transverse arch. So it's not a simple sort of, oh yeah, this is what it is. So we look at everything to see, exactly what is this diagnosis. We're also interested in whether they have arrhythmias, which is not uncommon with a lot of our patients. If they had other procedures beforehand. That's very important. And then what procedure do we perform? A good example, people think, oh, well, you're going to close the atrial septal defect. Well, there are different ways of closing an atrial septal defect depending on what kind of atrial septal defect it is. We just did a child who had a coronary atrial septal defect where we had to actually reconstruct the whole atrial septum and baffle the drainage going into the left atrium, across the left atrial wall, down into the right atrium where it belonged. So, no, we don't just throw a few stitches in and put a patch in. It's much, much more complicated than that. And then I didn't put all of the information here. I wanted to give you an idea of some of what we have to fill out. And then this is AV canals. Let me go to the next thing here. And then there are procedure-specific factors. A lot of these, like if we say that, like for a tetralogy of Fallot patient, which is a fairly common congenital heart abnormality, you have to become very specific in terms of how you're operating on this child. Oh, yeah, we closed the ventricular septal defect. Well, did you take out the pulmonic valve, and did you take out the right ventricular muscle, or did you just divide the right ventricular muscle and put a patch over the right ventricular outflow tract? I think you can see what's done at the operating table. We're trying to be very specific in this database so that we can compare apples to apples and try to get a little bit smarter in terms of should we be doing a particular procedure. One of the big issues right now is tetralogy of Fallot in the neonate. Should we be doing a complete repair, or should we do a palliative procedure, put a Blalock-Taussig shunt in, that is getting blood from an artery off the aorta and into the pulmonary artery, let the baby grow, and then do a more definitive repair? These are questions we're trying to answer. In terms of our operation, we need to know, is it an elective, urgent, emergent? Is it salvage? Where is it done? A lot of our PDA ligations in the neonates, I would do in the neonatal intensive care unit. Other people disagree with that. They want to do it into the ICU, in the operating room. And in terms of packed cells, did we have to give blood? This is very important when you're talking about pediatric patients. And yes, we do cabbage procedures in pediatric patients. And there are specific patients that require this. And we do a lot of valve procedures, and it's not mechanical valves usually. We usually try to repair the valves. And in the pediatric population, ventricular assist devices are being developed. What's available on the market is the Berlin heart. But we have now recognized that we have the ability to put in ventricular assist devices. If they're older and bigger, we can use some of the other devices that are available. These are the complications. We are required to say, yes, I had a complication. At the end of the operation, we put in data. This is ongoing. It doesn't stop. We have to say, yes, I had a complication. I saw the patient later on. Yes, the valve got infected. You don't just say everything's hunky-dory, they left the hospital. It doesn't work that way. And not only that, we are required to say, patient died or had a major post-op complication, yes or no? If yes, was it reviewed at a conference which we know as cardiac surgeons we should be reviewing, or is it scheduled for review? So these are things that we're trying to improve on in terms of quality of care of these very complicated patients. And similar things are in the other databases, the adult cardiac, the thoracic, and the imetics. Well, we get something called executive summaries. And it's a very high-level review of each database for the reporting period. And unfortunately, statisticians get involved in this, and I'm sitting down and looking at all this, and I'm saying, is this meaningful, is this meaningful, is this meaningful? And you have to sit there and you have to review it because you want to know if you're doing good or not doing good. So they do something very nice for us. So this is overall in the database. Our congenital database is not just the United States. We also have international. We encourage international. And the operations that were in analysis for 1 year was over 10,000. Patients in analysis was over 9,700 in the last 4 years. These numbers, by the way, are getting higher, and they give you very nice graphs, pretty graphs that you can see and see how we're doing more and more cases. And it gives you what the overall mortality, the number of mortalities, and the mortality percent. Now, this is overall. What they also do is break down for what's called the different stat categories. and they give you the number of procedures that were done. So an ostium segundum atrial septal defect or a type 2 ventricular septal defect, those are fairly considered simple procedures. Hypoplastic left heart syndrome, HLHS, is a very complicated patient. So when we start looking at what the mortalities are, if you look at ASD repair, percent mortality of 0.1%, Fontan 1.2%, VSD patch repair 0.2. But when you start looking at the complicated patients, they're much higher. And then on things like the hypoplast, you've got to look at what kind of a hypoplast was it, and was it a higher risk? Because 15% in the high risk is an acceptable mortality in, say, like an aortic atresia, mitral atresia hypoplast patient. So you have to compare apples to apples, and that can be difficult sometimes. And you're looking at benchmarks. They look at ours and they say, this is where you compare to your benchmark. So I want to talk a little bit about the National Cardiovascular Data Registry. And there are a lot of data registry. It's the American College of Cardiology's suite of data registries that helps hospitals, health systems, and practices measure and improve the quality of cardiovascular care they provide. It's more than just data collection. It's a comprehensive network of cardiovascular care providers committed to ensuring evidence-based care, improving patient outcomes, and lowering healthcare costs. And there are 10 registries right now. Okay, the TAVR, this is a hospital registry. This is number 8. Okay, we have hospital registries and outpatient registries, and the majority of places are in a registry. Like with us, we're in the impact registry. We're pediatric here. But on the adult side, they have chest pain, AFib ablation registry, cath PCI. We're also in the ICD registry. This is a left atrial appendage occlusive registry, peripheral vascular registry. Diabetes is a population of patients that's very difficult. They're high risk for cardiac disease, stroke, renal disease. Pinnacle registry, I'll go over a little bit. It's pretty much all patients. So chest pain MI registry. It's a risk-adjusted, outcomes-based quality improvement program that focuses exclusively on high-risk ST-elevated MIs, non-ST-elevated MI patients who have had a heart attack. It helps hospitals apply the American College of Cardiology clinical guideline recommendations in their facilities and provides invaluable tools to measure care and achieve quality improvement goals. Every adult hospital I know is in this registry. AFib ablation registry. It assesses the prevalence, demographics, acute management, and outcomes of patients undergoing atrial fibrillation catheter ablation procedures. As I said, in the past, we used to ignore atrial fibrillation. We have learned that's not a good idea right now. Its data will support the development of evidence-based guidelines for atrial fibrillation treatments that will improve outcome for patients, quality and quantity of life. The cath PCI registry assesses the characteristics, treatments, and outcomes of cardiac disease patients who receive diagnostic catheterization and or percutaneous coronary intervention procedures. It's a powerful tool. This is really helpful. It captures the data that measure adherence to ACC/AH clinical practice guideline recommendations, procedure performance standards, and appropriate use criteria for coronary revascularization. And as I've said, these clinical practice guidelines, procedure performance standards, and appropriate use criteria, these are open to everyone. They're open to the public. Anyone can look these up. The ICD registry It's a source of evidence-based data collection reporting for ICD. CRT is cardiac resynchronization therapy procedures, and it helps track ongoing compliance with updated national coverage determination. It plays an important role in determining the association between evidence-based treatment strategy and clinical outcomes. More and more patients are needing ICDs. And this cardiac resynchronization therapy, we're finding that's extremely important in heart failure patients. The impact registry, we're in that. It assesses the prevalence, demographics, management, and outcomes of pediatric and adult congenital heart disease patients who undergo diagnostic catheterizations and catheter-based interventions. Its data support the development of evidence-based guidelines for congenital heart disease treatment that will improve outcomes for congenital heart disease patients of all ages. This is really an important registry. There's a lot of debate in terms of interventional techniques in the pediatric patient, and this is helping us to decide which route we should go, surgery or interventional cardiologist. The LAAO registry captures data on left atrial appendage occlusion procedures to assess real-world procedural outcomes, short and long-term safety, comparative effectiveness, and cost-effectiveness. LAAO provides a treatment option to manage stroke risk for non-valvular atrial fibrillation patients who are unable to maintain adequate anticoagulation through medication therapy. It's approved by the Centers for Medicare and Medicaid Services to meet the registry requirement outlined in the national coverage decisions for percutaneous left atrial appendage closure. One of the things with atrial fibrillation is that it's more common than what we thought. You can be in sinus rhythm, you can have a Holter monitor, everything's hunky-dory, and your patient has a left atrium that's a little large, and oh, by the way, there's a clot in the left atrial appendage, and oh, by the way, they've had a TIA or a stroke. And the question is, if there's clot in that left atrial appendage and you don't have documentation of atrial fibrillation, should you close it? My answer is yes. And the reason is because we cannot always find the atrial. When you see the AFib, that's fantastic. When we can't pick it up because the patient is having it when we're not monitoring it, that's a different story. So the question is, this is trying to answer a very difficult question. The PVI registry assesses the prevalence, demographics, management, and outcomes of patients undergoing lower extremity peripheral arterial catheter-based intervention and includes carotid artery stenting, carotid endarterectomy. This registry provides data collection, equips clinicians with decision-making data, whether care is provided in a hospital cath lab, interventional radiology department, or an outpatient vascular center. So it used to be with a carotid endarterectomy, all of those were open procedures. But now we've got technology where we can stent it, and we don't have to make cuts. And many of the adult patients, you don't have to intubate them and put them to sleep. You can give them a little bit of medication. You can make them a little sleepy, and you can do it as an outpatient if it's safe. So we're trying to answer what's the best practice. And this registry I've already talked about. The transcatheter aortic valve replacement registry, it is a collaboration between the surgeons and the cardiologists, and it monitors safety and real-world outcomes related to TAPVR and repair procedures and emerging treatments for valve disease patients. We're hoping that as we get more information, we can offer the procedure in the United States to younger and younger patients. The Diabetes Collaborative Registry is important. It's the first clinical ambulatory registry aimed at tracking and improving the quality of diabetes and cardiometabolic care across the primary and specialty care continuum. This registry is the effort of a broad collection of organizations with the common goal of improving patient care and treatment of diabetes mellitus. And unfortunately, diabetes mellitus is very, very, very common. The combined data from primary care physicians, endocrinologists, cardiologists, and other diabetes care providers allows for longitudinal study of diabetes, making this a valuable resource that reveals new insights, drives decision-making, and enables better treatment and improved outcomes. The diabetics have in-organ damage in every organ system, and if there's something we can do to prevent that, that will give you a better quality and quantity of life. The Pinnacle Registry, it's cardiologists' largest outpatient quality improvement registry, capturing data on coronary artery disease, hypertension, heart failure, and atrial fibrillation. It has easy-to-interpret reports that help inform quality improvement, and the people who are in this can benchmark quality using guideline-based performance measures. Data are captured through a secure HIPAA-compliant data collection tool that works with most electronic medical record systems. And the registry, the participants gain access to NCDR's suite of clinical toolkits to help the clinicians implement best practice care to address common quality issues at their particular facilities. They can also use the registry to track quality for federally mandated programs such as the Quality Payment Program and promoting interoperability, formerly known as meaningful use. So these registries are important in helping our patients. Impact, I'm going to talk about it a little bit. This registry allows us to measure the variability in the performance and outcomes of both diagnostic and interventional cardiac catheterization procedures in all children, and it also includes adults with congenital heart disease. It harmonizes with the Society of Thoracic Surgeons. We're trying to make these two crosstalk right now. The STS Congenital Heart Database and the Impact Registry, we haven't been successful yet, but we're trying to get them to crosstalk so that we have a better idea of the different interventions, and is cardiology intervention better than a surgical intervention or vice versa. So it collects demographics for pediatric and adult congenital heart disease patients undergoing diagnostic catheterizations and catheter-based interventions. It gives provider and facility characteristics, the data for diagnostic cath procedures and 6 defined interventional procedures, adverse events rate, and data necessary to participate in the American Board of Pediatrics mock Port 4 credit self-directed performance improvement program, reducing radiation risk. That was an awful lot of information, and I wanted to give you what I think are the important points of all of this. First of all, a team approach is normal and expected. There are a lot of different subspecialties taking care of these patients. Clinicians and hospitals taking care of patients with heart disease, we have guidelines. They are dynamic, and they are expanding. Quality control is a major goal in all of these programs. There are many overseers in cardiothoracic surgery and cardiology at the local, at the national, and at the international levels. Cardiothoracic surgery and cardiology in the United States are tightly monitored and tightly controlled. The cardiothoracic surgeons and cardiologists are involved in quality control and improvement of existing programs, not limited to the facility that grant credentials. One of the things that we have to do to recertify in cardiothoracic surgery is to prove that we are involved in improvement of quality control at our particular facility. Quality and quantity of life is the main goal of treating a cardiology and or a cardiothoracic surgery patient. What may work in one patient or institution may not work in another. Individualizing the treatment and goals for a particular patient is necessary and good medicine. This is not a one-physician, a one-person decision. These patients are discussed among a lot of different clinicians, usually at the CATH conference. And importantly, just because we can do something does not mean that we should do it. And with all of that, I want to thank you for your attention.
Thank you, Dr. Mahan. If all the attendees can enter in the passcode for today, which is HEART, and any questions that you have. Our first question, what is the mortality rate for patients receiving new heart valves?
Can you give me can you put
it up?
It's
coming up now. Mm-hmm.
The problem is that you have to define which patient population that you're looking at. If you look at a national average, it's about 2%. But if you start adding different morbidities, that increases it, and the reason for the need for replacement also is critical. One of the problems we're running into with our cardiologists, not so much in aortic stenosis, but in aortic insufficiency, there are no well-defined clinical indications as to the timing of repair or replacement of the aortic valve and aortic regurgitation. And the unfortunate thing is that the cardiac surgeons are getting these patients later when you already have end-stage heart disease. So one of the things you have to look at how sick the heart is when you do the replacement. If you've got a nice heart, that's healthy, about 2% is the number that's quoted.
Okay, and I am putting up the next question for you.
Thank you.
Mm-hmm.
Do the specialty societies for cardiologists and cardiovascular surgeons get involved in sanctioning members? Yes, actually they do. This is a topic of discussion, and actually I wish they would involve more lawyers in the Society of Thoracic Surgeons meetings and the AATS meetings, because we know what our guidelines are and everything, and certainly we are not discouraged from helping with expert testimony. The recommendations are be very specific and go according to the guidelines. The majority of these cases that go to court, they're the ones that end up in courts. Usually, they're in a very gray zone, and there are individuals who would do one thing. There are other individuals who would do the other thing. And if you look at guidelines and stuff, you can find arguments for both sides. So generally, I have worked with lawyers, and what I tell the lawyers is I will give my best opinion on this particular case, and I will pull the literature and I will go over it with them if in a particular case. The ones that are solved out of court are usually, a mistake was made, everyone recognized it, and that's, the end of the discussion. The ones that go to the courts, though, they're usually very gray. They're in that gray zone.
I'm sending over the next question to you.
Thank you.
Mm-hmm.
If I had AFib ablation, what type of information is maintained in the registry? I'm sorry, I'm a cardiothoracic surgeon. I'm not usually one of the people who does atrial fibrillation ablation. But generally what they talk about is things like mortality, how long did it last, what kind of an ablation was it, was the left atrial appendage occluded, what medications are the patient is, what's the follow-up, that sort of thing. You can actually go to this registry and pull out information from this registry. It's not something I input. I apologize for that.
And our last question is coming over now.
Thank you. No. A stroke is not generally a sign of an error in the procedure or merely, I don't like to call it a side effect. First of all, if you look at patients who need an aortic valve or an ascending aorta or something, many of them have very calcified aortas, or they have calcified aortic valves or calcified annulus. And one of the things that many people are doing right now, and actually they're getting CTs of the head before the surgery, and that may actually underestimate the incidence of previous stroke. Stroke is a very broad term, and you can have a massive stroke and not have, as evidenced on a CT scan or an MRI, and not have a lot of clinical findings. Or you can have a little bitty tiny stroke and have massive clinical findings. It depends on where the stroke is. The problem is with our patients, first of all, if you've had a previous stroke and they need heart surgery, be it by transcatheter aortic valve or an ascending aorta, for whatever reason, it doesn't matter what it is, that cross-clamping the aorta, although you've looked at the aorta, and most of these aortas in the older patients are calcified or they have debris in the aorta that's part and parcel to them, we use techniques to minimize anything being dislodged. And in terms of the calcium or whatever, we do everything in our power to get rid of any debris when we remove the aortic valve or whatever, and then put in the new valve. The incidence of stroke, it's unfortunately a morbidity we see in too many patients, and everyone is very, very cognizant of that. And everyone is doing everything, everyone I talk to is trying to minimize the incidence of stroke. And there are things we do in terms of managing the anesthesia, in terms of managing the temperature of the patient, in terms of clamping, in terms of how we manage the heart-lung machine, in terms of medications we use to minimize the risk. If a patient has already had a stroke or even a TIA, they are at higher risk for a stroke or TIA post-procedure. The other thing is many times, yes, you do carotid ultrasounds, even if they're clean. There's stuff generally in the brain. The disease, atherosclerosis, is not just in the aorta. It's in smaller vessels as well. So if you change pressures, something that may not be significant when you're not on the heart-lung machine can be significant when you are on the heart-lung machine. So unfortunately, stroke is a complication that is recognized. When I talk to patients, I don't care if it's an adult or a child. Even when I'm talking to parents about a newborn, and I'm telling people this is a very real, recognized complication. We worry about it. We do everything in our power that it doesn't occur. But unfortunately, it does occur, and this is the percent that we see it in. So I hope that answered the question regarding that, because that's a common question.
Thanks, Dr. Mahan. Please remember that if you are applying for CLE credit, you must have attended for the full 120 minutes of this presentation. You are also required to complete the survey at the end of the program. Please note that you will be receiving your certificates via email in 24 to 48 hours. I want to take this opportunity to thank everyone for attending, and most especially Dr. Vicki Mahan for her time and effort in creating this presentation. If you would like to speak with Dr. Mahan, or if you would like to speak with a TASA representative regarding an expert witness for a case you are working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. Again, thank you all for attending. This concludes our program for today.